Okay, good night everybody. My name is Seniha Ozudogru. I'm a headache specialist here at the U. So today we are going to talk about other headaches other than migraines. So mostly we talk about migraines and migraine-related comorbidities. So today I want to talk about what other diagnostic headaches are there. So the most common headache syndrome is tension type headache. So it's mostly thought that tension type headache is the headache it starts back of your head, and it's mostly because of the muscle tension and muscle tightness. But migraines can localize to back of your head as well. Or migraine associates with light sensitivity, but tension type headache sometimes can associate with light sensitivity or sound sensitivity as well. So the main difference between migraine and tension type headache is migraine associates with nausea. Tension type headache does not associate with nausea. And when the activity makes migraine worse, whereas activity makes tension type headache better. So people who suffers from tension type headache, they like to go to gym after work, or they like to take a walk when they have a headache because it helps for their headache. So that's the main difference. If activity makes your headache worse, it's most likely it can be migraine with other symptoms as well. And if the headache is getting better when you are active, if it is distractible, that it's more likely tension type headache. It's not only about the localization. So the second one I want to talk about. Any question about tension type headache? So it can be episodic or it can be chronic, like migraines. If someone is having headaches more than 15 days a month, more than 3 months, that it will be called as chronic tension type headache. So the second type headache, it gets confused with migraine, is sinus headache. So many sinus headache diagnoses by patients themselves are actually migraine. So migraine can cause headache on your face around the areas that the sinuses or sinus headache will cause the same. But if your sinuses are clean, if you don't have any acute sinusitis symptoms, including runny nose, like yellowish thick runny nose, signs of acute sinusitis, or you don't have recurrent chronic sinusitis, probably you don't have sinus headache. Okay, so sinus headache usually happens with yellowish discolored runny nose and other symptoms like flu-like symptoms, maybe sore throat, postnasal drip, they associate with it, and very unlikely it's going to be chronic. Okay, only people who have chronic recurrent sinusitis, they have sinus headache. So in migraine or any kind of headache, the brain itself, the brain tissue doesn't hurt. There are a couple things hurt in the brain. Meninges, the membrane of the brain hurts, the blood vessels hurt, and the sinuses hurt. So people who have migraine, they might feel the pain on their sinuses area on their face like a sinusitis because it's a radiating headache. And it's the same nerve system. It's supplying to, it's kind of pathological, in the pathological mechanism of migraine that also innervates the sinuses. So it can overlap or it can get confused. Okay. So the other headache type, we are seeing many new daily persistent headache. So this new daily persistent headache is kind of new in literature as well. It's a headache that starts one day and never goes away. Usually you remember the date that the headache started. So if someone is coming to our clinic and saying that I am having this headache since February 24th of 2017, and I never had headaches before, and I never had suffered from migraine before. Then, and I never had any days without headache since that specific day. Then it's new daily persistent headache. It's very important to have this diagnosis because new daily persistent headache requires imaging studies. We need to do MRI to make sure there is no structural lesion causing the headache. We have to run blood tests to make sure there isn't any thyroid disease, vitamin deficiencies that's causing the headache. We also include MRA, the blood vessel imaging of the brain, to making sure there is no aneurysm or occlusion causing these headaches. So if someone is having a headache which is started one day and never gone away, requires complex workup. We have to make sure that we are not forgetting any, or we are not missing any underlying diagnosis. One very commonly talked disease under this headache is low pressure headache. So low pressure headache is a headache that it's postural. When someone develops postural headache, low pressure headache, they get headache when they sit up or stand up, and if when they lay down, headache goes away. It can happen post-traumatic, or it can happen idiopathic. We don't know why this person is having this kind of headache. But there are physicians or headache specialists, they think that maybe more than half of this new daily persistent headache actually the diagnosis of the misdiagnosed of low pressure headache. So when we see this diagnosis, we always ask about questions. Is this headache can be a low pressure headache that has been missed in the past? Because low pressure headache, as we said, when it started, it's very specific and it's postural. It gets better when you lay down. It gets worse when you stand up. So when you wake up in the morning, you feel good. You don't feel headache. But then when day goes, that you start having the headache, and you like to lay down because when you lay down, the headache gets better. But if the diagnosis wasn't made at the time, the postural component might become more blurry, and you might forget about how it happened in the past, and now it's kind of all the time. So it's important to think about low pressure headache when we are thinking about new daily persistent headache diagnosis. And it's really important to do the workup. So detailed workup required for new daily persistent headache. Sometimes chronic viral meningitis can cause new daily persistent headache. So that might require spinal tap. So even spinal tap can be considered in the workup for new daily persistent headache. Okay? And there is another headache diagnosis called temporal arteritis. So temporal arteritis is a disease of elderly. Usually a person who is older than 50 years old, who is having this new onset headache. It's either both temporal or one-sided, and it can associate with jaw pain. So when you are chewing, you might feel pain with the headache, and it can also associate with pain on the shoulders and pain on the hips. So there's a rheumatological disease called polymyalgia rheumatica. This temporal arteritis can go with polymyalgia rheumatica, and temporal arteritis is a rheumatological disease. So after the diagnosis, usually the rheumatologist, they might take over, or they might like to take over the treatment for this diagnosis. Temporal arteritis, it's a inflammation of the temporal artery. It's on the both sides. And inflammation is very specific. It's not continuous inflammation, it's a skipped inflammation. So the diagnosis, the first thing we do is a blood test called SED rate. We look for SED rate. If a person has very high, significantly high SED rate, then we start the treatment. And then we refer the patient for biopsy. Biopsy doesn't have to happen, but after the discussion, if we want definitive diagnosis, we do biopsy. Although if biopsy is negative, we cannot really rule out temporal arteritis if we have significantly high SED rate, because, as I said, it's not the whole blood vessel inflammation. It has skip lesions. So the area that we are doing the biopsy might not have the lesion, but it doesn't mean that you don't have this inflammation or this rheumatological disease. It's very important to diagnose on time and treat right away, because if we do not treat, that the inflammation can go further and it can cause blindness. And the treatment is prednisone. And the test, this blood test, SED rate, very cheap, very easy. Many clinics, they will be able to do this sedimentation rate test. Very easy test, because if we miss, the results can be significantly bad. The patient might lose their vision. So we have to think about temporal arteritis on an old patient, like age about after 50. If they are having this new onset headache and they do not have diagnosis of migraine, or even bad things can happen with people who have migraines, right? So we have to be aware of, is this my usual migraine or is something has changed? You can have 2, 3 different kinds of headache as well. So person who have migraine for years, they might develop a different kind of headaches years later. They might develop a temporal arteritis when they are in their 60s. So we have to be aware of there are different kinds of headache. Not every headache is migraine, and the consequences can be different, and we have to be aware of this so we can do the workup and then specific treatment for those headaches. So another kind of headache is called occipital neuralgia. We have 2 different occipital nerve in each side. There is a greater occipital nerve and then there is lesser occipital nerve. It's like when you have your elbow on the corner of the table, you feel like electrical zip pain. So these nerves, they are also superficial on the scalp. So when you have very minimal trauma, but it can be a consistent trauma, or you can hit your head on a cabinet, you might say, oh, okay, it was nothing. It didn't cause concussion. You didn't lose your awareness. You didn't lose your conscious. But it can hurt that nerve, and it can cause occipital neuralgia. The treatment and diagnosis of occipital neuralgia is very specific. First of all, when you have when you hit your head on the right side, the occipital neuralgia will be only on the one side, right? So it causes this unilateral headache. Usually it's a crescent shape because the nerve goes like this, and you can also feel the pain behind of the eye as well. So this crescent shape headache, and if you hurt the lesser occipital nerve, or if you hurt the both of them, you may also feel the pain around your ear. The lesser occipital nerve goes like this, innervates this area, and then the greater occipital nerve this area, and then behind of the eye. So you can get the headache based on which nerve you injured, and you might get the headache both kind of the extended area, the whole one side. And the treatment is blocking those nerves, and it's treatment and the diagnosis. What we do is we do occipital nerve block with local anesthetics, and after blocking the occipital nerve, if you are having improvement, if the headache goes away, then that's the diagnosis. If headache stays, then we can say that this is not occipital neuralgia. Sometimes you get benefit from nerve blocks, but it doesn't last long. You get benefit right away, but it doesn't last more than 24 or 48 hours. And you cannot keep getting the injections, right? So then if we are sure about the diagnosis, the way it's clinically presented, and the response to the occipital nerve block, we can consider RFA. RFA is radiofrequency ablation. Radiofrequency ablation gives relief from these headaches, but it's a longer time. It can help up to 1 year. It can be 3 months, 1 month, or 6 months, but it can help up to 1 year. If it doesn't help, we know the diagnosis, then we can consider surgery. Okay. There are specialized neurosurgeons. They can take the part of the occipital nerve if it is inflamed, or they can clean it around. And with the occipital nerve surgery, you will have permanent improvement. Okay. We do occipital nerve blocks for migraine as well. But with migraine, we know the diagnosis is migraine. It's plus minus, it's still debate. We don't know. There are studies showing it might show some improvement on migraine. It might help for migraine, but there are studies when they are still not showing enough statistically significant improvement. So it's not an FDA-approved treatment for migraine. But we do use, personally, I like to do bilateral occipital nerve blocks with other nerve blocks for chronic migraine treatments, based on the patient's presentation and needs, for sure. So the other things we can use, we don't have to go that way. We can use neuropathic medications like gabapentin, or Cymbalta, or amitriptyline. So we can go that route, and we can try medications after the diagnosis, or if we think that it will be safe and it's preferred by the patient, that we can go to that road as well. Okay, or we can combine. If occipital nerve blocks helps you more than a month, then you can, on top of it, you can combine it with a medication, so you might get a little bit further benefit, and you can keep getting occipital nerve blocks every 2 months, or every month. It's safe. Any questions about? Yep.
How long would they go on getting those nerve blocks?
Nerve blocks.
Indefinitely, or
there is no end day. Yes, unfortunately, there is no end day. As long as it helps, we can continue to do it. There is no cumulative side effect. So it's not like the longer you get it, you get these kind of side effects. So it's safe, so it can be done. When I say it's safe, it's if the physician is using steroids. There are physicians, they use steroid with nerve blocks. There are physicians, they only use local anesthetic. If you are getting the occipital nerve block with steroid in it, it may cause side effects. Because the longer you get steroids, the more steroid you get, that it can cause side effects. The main side effects it can cause is maybe scar tissue around the area that you get injections. And if you have diabetes, or if you are prone to have diabetes, you might get diabetes with steroid injections. So it has to be clear that if without steroid, local anesthetics, they don't really have side effects. Okay. Any questions about temporal arteritis or new daily persistent headache, sinus headache? Yep.
Regarding the new daily persistent headaches, we were talking about pressure, low pressure. Can that occur with altitude changes?
Altitude changes can make migraines worse. So migraine get affected from altitude changes. But altitude change by itself doesn't cause low pressure headache. Mm-hmm.
Okay.
It's usually low pressure headache. So I have one patient, she developed low pressure headache without a known trigger, but then after doing the imaging, we found out that she has some osteophytes, little bony little bones on her spine with the arteritis. The theory was maybe with the normal her daily movement that those osteophytes, they were causing the leak, the tear, and it was causing the leak, and she was developing low pressure headache.
So is it cerebral spinal fluid?
Yep, cerebrospinal fluid. Yep. Yeah. Yeah, the pressure, the low pressure. Yeah, I'm sorry. Yes, I should have been more clear about that.
I didn't understand what
yes,
the pressure
yes.
was.
The pressure is the pressure inside of the head.
Okay.
So the cerebrospinal fluid. Usually, you develop a leak from the cerebrospinal area. Usually, it's around the spine. And then with the leak, you lose the CSF, the cerebrospinal fluid, and it causes low pressure. And then it causes the headache. Okay? Thanks for asking. Mm-hmm. Okay. And there are other rare headache diagnoses. Hypnic headache, usually it's a headache on an elderly people as well. It's very unique. It only happens during sleep. And it wakes you up from sleep, and after 30-45 minutes, the headache goes away. And if the person is taking naps during the day, it can happen only during nap time, but it doesn't happen when they are awake. It only happens when you are sleeping. And it's called hypnic headache. There are minimal number of young people as well, and couple case report with kids, but it's the main patient population it was described is the elderly who are above age 50, and they wake up with a headache, very severe headache. It's usually bilateral, and they wake up 25-30 minutes or even 45 minutes sometimes, the headache goes away. And during the day, if you are reading those, like after age 70, 80, when you are reading, if you are dozing and then you are kind of falling asleep, you might wake up with a headache, but it doesn't happen during the day. It's a very unique headache diagnosis, and it has very unique treatment. The first line treatment is caffeine. So we ask them to drink a cup of coffee or Coke before they go to bed. With the caffeine, they do not develop headache, and it helps them to sleep throughout the night. So it's usually, right, when we drink caffeine, a lot of caffeine causes insomnia. You cannot fall asleep. But people who develop this kind of headache, hypnic headache, they are able to sleep without waking up with a headache. They sleep throughout the night with a cup of coffee or caffeine pills or Coke. So that's the first line in the treatment. If caffeine is not helping enough, then the medication is indomethacin. It's a very specific medication. It's an old medication. It's a non-steroid anti-inflammatory. But ibuprofen or Excedrin doesn't help. Indomethacin helps. Okay. Unfortunately, there are patients that they have hypnic headache, caffeine doesn't help, indomethacin doesn't help, and we try other medications. There are review articles, different physicians try different medications. We even tried the medications we use chronic migraines, but there isn't good results, unfortunately. The most commonly helped medication, if these fail, is lithium. But the age group and then the side effects from lithium, it's really an important decision to make. We have to make sure we do have their EKGs. We have to make sure we follow the level of lithium. So it's a little bit tricky. So we discussed with the patients, and then personally, I had one patient that nothing helped, and he didn't want to try lithium, and I haven't heard from him for a while. We weren't able to, I wasn't able to help him. And the headaches, they were so severe, and it was waking him up. But at the same time, he didn't want to try lithium. Instead of trying lithium, he said, I will wake up, and then headache will go away, and I will go back to sleep. That was his preference. I have tried amitriptyline, topiramate, those medications we try for chronic migraine, or those medications, they were reported in a couple case series, but nothing helped. And the result of those case series, they were also negative. They were tried on different patients on Hypnic headache, but they did not help. It's a very unique headache. If caffeine helps, that's a great diagnosis and treatment. You feel really good, and patient feels good. But if it doesn't help, and if indomethacin doesn't help, then it's very tricky. It can be very difficult. Okay. There is another headache diagnosis called Nummular headache. It's a rare and it's kind of still debatable diagnosis. There are physicians, they do not accept the diagnosis of nummular headache. It's the terminology is coming from Spain, and it's a headache that's kind of coin-shaped headache. And the patients describe the headache, it's like my skull hurt. It's not inside of my brain, it's the outside hurts. And it's very specific area, it's like a coin shape. It can be anywhere on the head, and the pain is always there. It can cause sensitivity, hyperalgesia or allodynia. Hyperalgesia meaning that if you use a needle to do like pinprick, that it hurts, but if you do it around the area that you have the pain, it hurts significantly bad. Or pressure doesn't hurt, but if someone has allodynia, around the area they have the pain, it hurts. We do not have great understanding of nummular headache, but there are some theories. One of the theories that it is a neuropathy of the small branch nerves, that if a person is having that neuropathy around the area, that it's causing this continuous pain. There are medications reported it can help for nummular headache. I personally like to do little local anesthetics around the area. I also like gabapentin for this kind of headaches. It can help. Okay. I have talked about trigeminal autonomic cephalalgias, but maybe we can talk about those. We can involve those as well as a non-migraine headache diagnosis. If you are not tired and you are okay with it. Okay, and we have enough time, right? Okay. So I can maybe go here. So trigeminal autonomic cephalalgias, they are unique headache diagnosis. It includes, it's a big title, and there are different headaches under it. So the one big group is cluster headache, and the other one is paroxysmal hemicrania or hemicrania continua, and the other ones are Sanct and Suna. So to be able to understand, Sanct, it's S-U-N-C-T or S-U-N-A. It's a sudden unilateral neuralgia form headache with conjunctivitis and tearing, or sudden unilateral neuralgia form headache with autonomic symptoms. So to be able to understand the trigeminal autonomic cephalalgias, we should know about what's autonomic symptoms. So if a person is having tearing from their eyes or runny nose, redness of their eyes, swelling on their face, or swelling on their eyelids, dullness sensation in the ear, these are called autonomic symptoms. Usual autonomic symptoms associated with trigeminal autonomic cephalalgias, but sometimes people who have migraine, they might have autonomic symptoms as well. With trigeminal autonomic cephalalgias, it's only on one side, so their headache on one side, and the autonomic symptoms happens on the same side. So they have this, we call it side-locked headache. So the headache is always happening on one side. Migraine is a unilateral headache as well, but migraine shifts. You sometimes have headache on the right, sometimes on the left. You can have headaches mostly on the right, rarely on the left, but it's still, even if it is rarely, it shifts. But trigeminal autonomic cephalalgias, they do not shift. They only happen one side and they do not go on the other side. It's one-sided headache with one-sided autonomic symptoms. So I have this headache on the right side and I am having tearing when I have headache. Or I have this swelling on my face. Or I have runny nose only on the right nostril. The left side is fine, only on the right side. Or I have this ear pain or the dullness sensation. Or instead of runny nose, they can get congestion. They get congestion on one side of their nostril. So then we think about the diagnosis of trigeminal autonomic cephalalgias. So the cluster headache, it's usually male patients more than female, unlike migraine, right? Migraine mostly female patients. Female gets more than males. And cluster headache, usually male in their early 30s. They get this headache. It usually starts around springtime. It's seasonal. It can start fall and spring, and you might get only one season, or you might get every spring, every fall. And it's one side with this severe excruciating pain. It's also called suicide headache. It's very important. We call our cluster headache patients, they are our VIP patients. If someone is having cluster headache, they need to be seen soon because the pain is so significant. They cannot sit still, they cannot sleep, they cannot do anything. It's unlike migraine. When you have migraine, you like to just go in a dark, quiet room and you do not like to move. If a person is having cluster headache, they cannot get rest. They are being restless. They keep moving. They might hit their head on the wall. It's very severe pain. And it comes in attacks. The attacks can last from 4 to 5 minutes to 1.5 hours. And during the attacks, they get all this, again, one-side headache with the autonomic symptoms. The attacks also comes around the clock. So it's seasonal and it's also around the clock. So person can say that I am having attacks at 1 p.m., 5 p.m., and 1 a.m. and 3 a.m. Every day, same time. It continues every day, same time during that season. And then when it is summer, he's totally fine. When it is winter, he's totally fine. And when the season is changing, then they start their attacks of that season, and the attack starts again. The side of the attack can change season by season, year by year, and then the timing of the attacks can change season by season or the year by year. It can turn into chronic, unfortunately. Like every headache, when they turn into chronic, the treatment is more difficult. The main treatment for cluster headache is oxygen. It's with non-rebreather mask. It's not nasal cannula. It's non-rebreather mask, 100% oxygen, high volume oxygen. It's 10 to 15 liters. So usually physicians are very good at catching cluster headache because it's very unique headache. But it's very important to know how to give the oxygen. The commonly mistake is being made is giving the oxygen 2-3 liters by nasal cannula. That's not the treatment. The treatment, high flow oxygen, 10 to 15 liters with the non-rebreather mask. If oxygen doesn't help, or oxygen helps, but we want them not to get the attacks. Oxygen only treats the attacks. When they get a head attack, they put the mask on, they get the treatment, so then their headache doesn't last 45 minutes, it may last 10 minutes. But then they are keep getting the headaches, right? So we use high dose prednisone. If these don't help, or patient has contraindications for prednisone, the other medication, commonly used medication, is verapamil. Okay. There are other medications we can try, we can use when it becomes chronic. These might not help, but I don't want to talk more details about those, unless you have a specific question about. Okay. Hemicrania continua. Hemicrania continua is more female predominant headache. And there are times, I don't know how many patients I had so far, but I have had multiple patients that they actually had hemicrania continua, but they were diagnosed with migraine and they didn't get the treatment for hemicrania continua, and their migraine did not respond to any medication. So it's very important to think about hemicrania continua if someone is having one-sided headaches, not very obvious autonomic symptoms, or they don't talk about their autonomic symptoms until you ask them. Sometimes as a physicians, we might not ask the appropriate questions, or we might not think about that at that point. And as a patient, you might not think that it's important. So if this is different, the headache is not crossing the other side, it's only one side, it's important to mention your physicians, maybe can it be a different headache? Can it be one of those trigeminal autonomic cephalalgias? So sometimes it can be very subtle. You might have a couple tears and you might not pay attention. You don't think that it's always on the one side, on the same side with the headache, and it can be missed. So hemicrania continua can start as a paroxysmal hemicrania, attacks of headache 1 to 3 hours, and it's not like cluster that you become restless. It can be like migraine, you don't like to move, and you can get light sensitivity like migraine, but the difference is light sensitivity is only on one eye, not on the other eye. Sometimes patients say, when I am talking to them, it's important to spend some time so then you can understand. If they are showing that I close my eye every time when I have a headache, that's a good sign that it's hemicrania more than migraine, because she's showing one eye and closing that same eye all the time. The treatment for hemicrania continua is indomethacin. So we talked about indomethacin can be a medication for hypnic headache, and this is another disease. We use indomethacin for the treatment. We also use indomethacin for diagnosis. The hemicrania continua diagnosis is made based on the response to indomethacin. If you are responding to indomethacin, then you have hemicrania continua. If you do not respond to hemicrania, if you do not respond to indomethacin, then we have to rethink about the diagnosis. The dose of indomethacin is very important too. Sometimes the indomethacin, because it's a non-steroid anti-inflammatory, the physician might be worried about the kidney function, and they might not increase the dose, and then you do not get good response. So it has to be tried up to 225 milligram per day. So So I usually start with 25 milligram 3 times a day for 3 days, then increase to 50 milligram 3 times a day for 3 days, and then, 75 milligram 3 times a day. And after 2 weeks, if the headache is gone, that's hemicrania. Or if you have significant relief, that's hemicrania continua. Okay? The other thing I should have told before, this Hypnic headache, Nummular headache, Trigeminal autonomic cephalalgias. If you are thinking about this headache diagnosis, that person requires workup. That person requires MRI with a specific trigeminal protocol for that one, not for this. And then even maybe MRA. Okay? So the workup needs to be done for these rare type of headaches because they are very rare and they sometimes associate with structural disease. So we have to be careful about it. Okay? And Suna, it's also unilateral headache with autonomic symptoms, but they are mostly around the eye. The pain is around the eye, and the attacks are in seconds. So the person gets multiple attacks, 20, 30 attacks per day. They get this attack, very severe, like a stabbing, sharp pain, and lasts in seconds, and tearing, the swelling or redness of the eye. If there is redness and tearing, then it's called sanct. If person has only tearing but no redness and other autonomic symptoms, then it's called Suna. Or if a person has only redness, not tearing, and other symptoms, it's called Suna. So it's not very important to know about the differentiation, but it's a different kind of headache. And it's very important, again, this headache also can be very severe, and it can cause significant depression. So we always say headache doesn't kill, but the depression kills, right? With chronic migraine, chronic tension type headache, they do not kill. They might not even cause a progressive brain damage, but because they associate with depression and anxiety, it's very important to get appropriate treatment. Okay? So that's sanct and Suna, and again, we use anti-epileptic medications for this, and we use IV lidocaine. Okay? The other procedure we might consider for trigeminal autonomic cephalalgias, it's called SPG block, which we can use for migraine with autonomic symptoms as well. There's a plastic catheter we put through your nose, and there's a ganglia, and the idea is showering the ganglia with lidocaine, steroid, and bupivacaine, and blocking that ganglia can help for those symptoms. Okay? Any questions? Yep.
Do the headaches commonly cause increased blood pressure, or does high blood pressure cause headaches? Are they interrelated at all?
Yes. So when you have pain as a pain response, your blood pressure increases. But if you are having blood pressure like 170 over 100 or 90, if it is significantly high, that's not a pain response. Yes, pain response increases your blood pressure. If you have a normal blood pressure, usually runs around 120. Your blood pressure can increase to 130, 140, and your heart rate also can increases. But if it is increasing significantly high, then we cannot really say that headache is causing the blood pressure increase. Blood pressure increase can cause headache. That's a good point. Hypertensive urgencies, emergencies can happen. Hypertensive urgency meaning that the high blood pressure, the blood pressure is significantly high enough, it's causing symptoms, signs and symptoms on the body. And headache can be one of them. You're cognitively intact, but you're having severe headache. And every time when you have high blood pressure, you are having headache, or every time when you have headache, you have significantly high blood pressure, so you might be having high blood pressure related headaches. Okay, and that reminds me, a very important diagnosis, it's RCVS. It's reversible cerebellar vasoconstriction syndrome. If someone is having thunderclap headache, meaning that it's very severe, sharp, quick onset headache, like right away you are having the most severe headache in your life, and it's associating with some other neurological symptoms like weakness on one side, unable to talk, or double vision, then and it goes away after headache goes away, or it goes away after like a couple hours, we should consider about RCVS. What happens is with RCVS that you get multiple contraction on your blood vessels in your brain, and they can cause stroke-like symptoms. And if it continues, it can, or even the first time, it can cause real stroke as well. So that's very important to catch the diagnosis or think about the diagnosis of RCVS. You might not even have other neurological symptoms. You might only have the severe, significant, acute onset thunderclap headache. Right away, peak, significantly painful headache. That requires emergency room visit, and that requires MRI, MRA. We have to make sure we look all the blood vessels, and we have to make sure that we don't see that vasoconstriction on multiple sides of the arteries. Okay. If a person who has migraine, or if a person who has some chronic headache diagnosis, if they are having different kind of headache, and this different kind of headache causing weakness on one side, double vision, unable to speak, slurred speech, you have to be careful, and you might consider going to the ER, because stroke associates, there is an association between stroke and migraine, especially migraine with aura. But at the same time, there is a diagnosis of hemiplegic migraine, right? So migraine can cause one-sided weakness, but it's not stroke. So the difference is important. If you are having symptoms like right away, in a second you have weakness on one side, that's a more sign for stroke. If you are having progressive symptoms, you start having numbness here, going up, going down, it's more for hemiplegic migraine. So these are really important to differentiate. I'm kind of out of my topic. I wasn't thinking about talking about this, but it's really important to consider those. Okay. We don't want our patients to go to ER all the time. Our goal is to keep them home and then treat their headaches, right? That's the goal. We don't want them to suffer severe, significant headaches that they cannot treat, and they have to go to ER. But at the same time, we want to make sure that they know the emergency signs and they go to ER appropriate times. Okay. Any questions? Do we have any questions from online? Okay. Do you have any questions?
Well, a lot, but not
on this topic?
Yes, exactly.
Understood. Okay. Okay. We can wait. We have 10 more minutes. We can wait a couple more minutes to see if we are getting any questions online. If not, I think we can finish. Perfect then. Sure.
What's the thought process? How does lithium help with those hypnic or
Hypnic headaches?
Yeah. How does that help?
Pharmacologically, how does it help?
Yeah.
I don't know.
Okay.
I don't know that detail. Yep.
Okay.
Okay then. Good night. Thanks for coming, and thanks for joining.